Okay, I have 7 o'clock, so we'll go ahead and get started. And before we get to grand rounds, I'd like to make an announcement to the faculty, staff, and trainees. As all of you are aware, we're in the midst of another major COVID surge, which has resulted in a lot of hospitalization of COVID patients. The good news is the same proportion are not going to the ICU, but nonetheless, a lot of COVID positive patients are being admitted to the hospital for symptoms. And I just got finished with a meeting with the division chiefs and division administrators going over a potential plan, which your division chief will go over with you, where up to 2 COVID patients will be admitted per surgical service. And the details are still being worked out. We have some rough details that your division leaders will go over with you. But the key is, none of us want this COVID pandemic. Some of us are uncomfortable stepping out of our normal activities and doing things and taking care of patients we're not familiar with. But we may have to roll up our sleeves and do this. And please be polite to the poor person who may be from hospital medicine or hospital administration, or maybe even surgical administration, asking you and your team to take care of these patients. Not sure if this plan will actually be activated or not. It's probably 50-50 right now. And there's a very organized tiering system and trigger points to when the Department of Surgery gets activated. So just a heads up, more details to follow from your division leaders. And thank you. And thank you for being available, affable, and able in taking care of these patients if we're called upon to do it. So today's grand rounds, we have 2 great topics. The first topic is update on thyroid cancer. This will be presented by Dr. Chris Raeburn. I think everyone in the department knows Dr. Raeburn. Chris, he's a member of the GITES division. He did his undergraduate training at Miami of Ohio and did his medical school at Case Western, and then came to the University of Colorado to do both his general surgery residency program as well as endocrine fellowship. And we were lucky enough that he stayed on and has led many great things here at the University of Colorado. He has also been single-handedly responsible for recruiting a lot of people from Case Western into our residency program and other positions. He's really known as an excellent technical surgeon. If you had to characterize the modern general surgeon, that would be Dr. Raeburn. He specializes in the neck and in endocrine surgery, but he's still a surgeon who's very comfortable all over the body and takes care of complex general surgery patients. He's also a great teacher, and many of our residents seek him out for surgical training, and they love rotating with them. And on top of that, he has done a lot of work organizing the surgical services, especially on the 6th floor. Keeping things in order and making that one of the highest rated units in the hospital. And with that, Dr. Raeburn, I'm going to turn it over to you. Thank you very much for your presentation.
Thanks, Rich, and good morning. Are you able to see my screen here?
Yes. Yep, that's perfect.
All right, great. Good morning, everybody. So this is going to be an update on thyroid cancer. We're going to talk a lot about kind of how we're trying over the last 5 to 10 years to really titrate the dial and get the appropriate treatment for low risk versus high risk patients with thyroid cancer. I have no disclosures. So the incidence of thyroid cancer is increasing faster than any other cancer over the last 30 years. It's tripled in number. And we know that it's much more common in women than men, about 3 to 4 times more common, and it's currently the 5th most common cause of cancer in women. Thankfully, the outcomes for the majority of patients with thyroid cancer is excellent. So most thyroid cancers are papillary thyroid cancers, which are indolent, and the 5-year survival for thyroid cancer is in the high 90s. So, that's the good part, that the outcome is excellent for most patients with thyroid cancer. However, there are complications to treatment. So injury to the recurrent laryngeal nerve can result in significant hoarseness that can be a major quality of life problem for patients and impact their employment. There wouldn't be a hypoparathyroidism association if surgeons were as good as we thought we were at protecting the parathyroids. And severe hypoparathyroidism, again, can be a major quality of life problem. The radioiodine can cause chronic dry mouth or dry eyes, has a small risk of inducing other cancers, especially leukemias, if used in high quantities. So there's also, a large psychological and financial impact of thyroid cancer, which is perhaps a little bit disproportionate to what we would think there would be based on the good outcomes. This study actually looked at quality of life in thyroid cancer and compared it to some other cancers, some of which have much worse prognoses. And it found that the quality of life reported by patients with thyroid cancer is actually no better than many other cancers. And for the overall quality of life was actually worse than for breast cancer, and equivalent to other things like colon and gliomas, which have much worse outcomes. Worry in thyroid cancer is also very prevalent. So worry has been something that's been studied in a lot of other cancers, but there hasn't been a lot of work in thyroid cancer. This was done using the SEER database, over 2,000 patients who reported being thyroid cancer free and were 2 to 4 years out from their thyroid cancer diagnosis. And still, in this very favorable prognosis cohort of patients, over 50% of patients still worried about recurrence, 40% worried about death, and felt that this was changing and impacting their quality of life. And there seemed to be this disconnect between the risk that patients actually have of recurrence or dying of thyroid cancer and the worry. And the worry, both from the patient and the provider, impacts the frequency of surveillance, the use of radioiodine, and the extent of surgery or surgery for small local recurrences, which in many cases could be actually just monitored. And the authors, stress that there needs to be recognition of this worry, and to do things to try and mitigate that, to not allow that worry to drive unnecessary treatments. The other thing that thyroid cancer can do is be a huge financial burden. So we know that 2/3 of people who go bankrupt, that there's actually a medical issue that prompted or contributed to that bankruptcy. And this is a large study looking at over 200,000 patients with various cancers. And it did show that the hazard ratio for going bankrupt increased 2.6 times that over patients who did not have cancer. And again, somewhat surprisingly, that thyroid cancer had one of the highest hazard ratios of any of the cancers studied. The theory behind this is that thyroid cancer tends to occur in younger patients who actually might have a higher debt to income ratio and often do not have high quality insurance yet, and so they may have higher deductibles. Truthfully, bankruptcy is likely just the tip of the iceberg. This is another study in 2020. Again, nearly 2,000 thyroid cancer patients looked at the financial burden and quality of life of a diagnosis of thyroid cancer. And this study did find that 3% of patients reported declaring bankruptcy. But other things, 24% of patients had used up all or most of their savings, and another 16% had been contacted by a collection agency. It was also, not surprisingly, patients that did have financial hardship it impacted their health-related quality of life significantly, and there was a clear association between the two. So what can we do? So one, we can avoid overdiagnosing thyroid cancer. So we're getting lots of studies out there, some of which have dubious reasons and indications for those studies. But again, that's really what's driving the incidence of thyroid cancer. You can see here in this graph that there's a 3- or 4-fold increase in the incidence, but the lower line here shows that the mortality really has not significantly changed over that time. So if all we're doing is finding early, indolent cancers and subjecting all those patients to treatment and the potential risk of financial and quality of life impacts without improving mortality, then, what are we really doing? And again, this study here is a little older now, but it was an autopsy study out of Finland that showed that if you really look hard for thyroid cancer, you can find it quite commonly. It was over 100 autopsies, and they found that there was a occult papillary microcarcinoma in 36% of patients. And they felt that was actually an underestimation. If they'd have done even thinner sections of the specimens, they would have found even more. So, what can we do to mitigate the overdiagnosis? Well, one is we can stop screening for thyroid cancer, and we don't systematically screen for it in this country. In South Korea, where they do, over that same period of us seeing a 3-fold increase, they saw a 16-fold increase because they were doing, just like mammograms, they were doing neck ultrasounds on all patients. So the United States Preventative Task Force recommends against that the actual potential harms in screening asymptomatic patients for thyroid cancer outweigh the benefit. Another is to make sure that we're using evidence-based guidelines for which nodules to biopsy. So fine needle aspiration is the mainstay of diagnosis of thyroid cancer, and thyroid nodules are quite common. So you really should be using published guidelines by either the American Thyroid Association, the NCCN, or the American College of Radiology has what's called a TIRAD system, similar to the breast imaging BIRAD system, that estimates the risks of thyroid nodules. And I won't go into the details of that, but there are certain features that increase risk. This is out of the ATA guidelines. And the bottom line is you really shouldn't be sticking a needle in anything under 1 centimeter. But following those guidelines will be a major way to decrease the overdiagnosis of small indolent thyroid cancers. The other is to use molecular testing. So about 30% of thyroid nodules on fine needle aspiration are indeterminate. We just can't tell. So we used to take out all of those nodules, and only about 20 to 30% of them turned out to be cancer. Well, we now have molecular testing that's commercially available that looks for any genetic mutations or gene expression changes that might predict cancer. And it's now rare to take out an indeterminate thyroid nodule without molecular testing that's further stratified the risk to be, higher than that 20 to 30%. The other thing that we can do is just stop calling it cancer. So this was an interesting study from about 5-6 years ago that looked at over 100 patients that had a certain variant of papillary thyroid cancer. It was called the encapsulated follicular variant of papillary thyroid cancer. They found that all of the patients in that group who had treatment, none of them went on to develop a recurrence or die of that subset of papillary thyroid cancer. So they actually renamed it. This hasn't happened many times in cancer, that they changed it to what's called non-invasive follicular thyroid neoplasm with papillary-like nuclear features. We refer to that as NIFTP. And that was all, aimed at reducing the psychological and emotional burden of a diagnosis of thyroid cancer, and to help reduce the side effects and costs of treating further treatment, like doing a completion thyroidectomy or treating with radioiodine when it was not going to be of benefit. This was really felt to going to be a big game changer, that a lot of patients were going to fall into this category. I really haven't seen that many patients who our pathologists are putting in this category. So it hasn't really impacted things as much as the initial press about it suggested it would. The other is to adjust staging. So the purpose of staging is to help stratify what the prognosis is and appropriately direct treatment to those in the higher stages to improve outcomes. So thyroid cancer is one of the only cancers that I think the only cancer that's staged differently depending on age. And so the age threshold used to be 45. The new guidelines that started use in 2018 increased that age to 55. They also de-emphasized things like minor extrathyroidal extension in the strap muscles or nodal disease. So the only way you can be stage 4 now is if you're over the age of 55 and have distant mets, or your tumor is literally growing into your spine or encasing your carotid or jugular vessels. Otherwise, you're stage 3 or below. So lots of people looked at their own data to look and see, is this new staging system going to help better stratify the risk in the different stages? And the left figure here shows that in the old, this version 7, that stage 1 through 3 all clustered very closely together. It's not very helpful. There was clearly a worse outcome in stage 4, but in the new guidelines, the staging system, that you can see there's a clear splaying out of the different stages. So it seems to be a better and more predictive, and we're hoping that this will also help to decrease overtreatment for the patients who are in the stage 1 and 2. So the other is we want to avoid overtreating thyroid cancer. So we know that there's lots of people out there that have microscopic or at least, clinically occult thyroid cancer that live happily ever after. And it was really the Japanese that were the first to really look at, well, can we just observe these patients? This is actually now a little bit older study, but it's sort of was the first one that really got the ball rolling on observation, or what we call active surveillance, of papillary thyroid microcarcinomas. This is defined as thyroid cancers that are 1 centimeter or less, without any nodal or distant disease and without any invasion or aggressive features. And so they looked at over 1,000 patients and gave patients a choice of observation versus surgery. And in this early cohort, there were still, the majority of patients chose surgery. But then the observation group just was, observed unless they had progression, and progression was defined as growth of over 3 millimeters in the tumor size or a new node met. And what they found was that at 5 years, only 6.4% of the tumors grew by 3 millimeters or more. And at 5 years, only 1.4% actually developed a new node met. And so, this has been a little slow to trickle across the pond, so to speak. But Memorial Sloan Kettering also has begun doing active surveillance, as well as some other centers. We do it selectively here as well. But this was one of the first papers in this country that looked at 291 patients, so a smaller study, only 25 months of follow-up, but their outcome was the same in terms of progression as what was seen in the Japanese study. And they actually observed tumors that were up to 1.5 centimeters. And an editorial recently said that they actually now are following over 500 patients and have increased the size threshold to as high as 2 centimeter in some patients. So this is definitely, happening. And I think it's a good thing for patients that are low risk. One thing, though, that's difficult is getting buy-in from patients and providers to do this. So it's hard to tell a patient, you have a small cancer, it's probably going to be okay. And this actually is looking at that same Japanese data as sort of the early versus more recent conversion rates. So the patients that were in active surveillance, how many of them converted to the surgery group? So in the top line here, in the early cohort, 12% of patients ultimately went on to have surgery. In the more recent era, only 4% did. And, that's basically what they're saying, is that people are becoming more comfortable with this. They also have they're allowing some patients to actually grow maybe a little beyond that 3 millimeter cutoff. And that they're actually having patients that even have new node mets, that they're small, that, so they're really the bar for what our comfort level for active surveillance is really evolving over time, but people are clearly becoming more comfortable with it. So active surveillance has found its way into the ATA guidelines, which is sort of the Bible of the treatment of thyroid cancer. And the guidelines say that, for most papillary thyroid cancers, surgery is going to be what's recommended. But for those with very low risk tumors, that active surveillance is a reasonable and safe approach. So it's in our guidelines, but I would say that it's still not quite prime time yet. Another approach would be to do percutaneous radiofrequency ablation. So again, not something that's being done very commonly for thyroid cancer, especially in this country. But again, studies in Asia have shown that for these small micropapillary cancers, that radioablation seems to be a safe and effective treatment. It's used also for benign thyroid nodules and goiters, but it's really been a little slow to transition, or to, hasn't gotten a lot of studies in this country yet showing that the outcomes are the same. But I get probably an email every 3 months about some new course that people are pushing to try and get me to learn how to do this. And we do have an IR person now who has been just started recently, who has experience in this. The other is, the guidelines have changed in terms of the extent of surgery. So back in 2009, if you had a cancer over 1 centimeter, it was recommended you have your whole thyroid taken out. But now that size threshold in the most current guidelines was increased to 4 centimeters. And we're all still, I would say, getting a little used to that. But, the advantage to just taking out half the thyroid is that you essentially have zero risk of hypoparathyroidism, half the risk of recurrent laryngeal nerve injury, and you can avoid the need for thyroid hormone replacement lifelong. All of those things can impact quality of life. Similarly, in the initial guidelines in 2006, it was recommended that if you're operating for papillary thyroid cancer, you should routinely do a prophylactic central neck dissection. That can increase your risk of nerve injury and certainly increase your risk of hypoparathyroidism. So with further study, the current guidelines say that we shouldn't be doing these prophylactic central neck dissections. They're rarely, really benefiting patients because of the indolent nature of the disease. So you really shouldn't be doing a central neck dissection unless it's an advanced primary tumor or there's clinically involved lateral neck nodes. So in summary, the thyroid cancer incidence is increasing, but the survival is excellent. Thyroid cancer, can significantly impact a patient's quality of life and be a burden financially to them. Ways to mitigate that are to avoid overdiagnosis and overtreatment by avoiding screening programs in asymptomatic patients, to use evidence-based guidelines for when to biopsy a thyroid nodule, to consider active surveillance for low-risk patients with micropapillary thyroid cancers, and to use, again, published guidelines for the appropriate extent of surgery and the judicious use of radioiodine. So, but what can we do in the future to further improve our treatment? So one is to use mutational analysis for prognosis and to guide treatment. So you can get a lot of information from these commercially available tests. And an example would be, you might have a 53-year-old woman who has a 2 centimeter thyroid nodule incidentally found on a carotid ultrasound. History and exam are unremarkable. You do a biopsy, it's suspicious for papillary thyroid cancer. The ultrasound's unremarkable, normal TSH. You do the mutational analysis, you recognize there's a RET PTC1 fusion, which is a low risk type of alteration, and all of the other high risk things are normal. So you might just monitor that patient. Same patient who has a 1 centimeter nodule, and you do the biopsy, it's suspicious, and they have recognized to have a BRAF V600E mutation and combination TERT mutation. Well, that's a high risk patient. So we should do a thyroidectomy, a neck dissection prophylactically, maybe do I-124 PET dosimetry to really zero in how much radioiodine we can safely give. And then if they have a persistent or recurrent cancer, then early use of targeted TKIs might be appropriate. So the other advantage we have here is to further study this is the Colorado Center for Personalized Medicine. So I think most of us think of the biobank when we think of that. And right now there are, over 34,000 patients who we have sequenced their genome and have that linked to electronic health records. And we actually have additional data that has not yet been released yet on those patients. But this is a study that I don't know Dr. Guignou or how to say his name exactly, but this was a large meta-analysis of biobanks, 19 biobanks over 4 continents, over 2 million patients that had genetic data linked to electronic health records. It's essentially a meta-analysis of genome-wide association studies done through different biobanks. And they examined 14 diseases. So we were one of the centers, and of the 6 centers in the US with 34,000 patients. I think we now have another 35,000 patients that the data will be released for soon. But so they looked at these 14 diseases, and it turns out that thyroid cancer is one of those diseases. And they found 27 variants, 15 of which were novel, that were associated with thyroid cancer. Just for comparison, just using our 34,000, and again, 34,000 seems to be a lot of patients, we only detected 2. So this shows the feasibility and power of combining these biobanks to show novel variants. This is Nikita Pozdayev. He's an MD, PhD endocrinologist who's a super genius that I have known for a while and collaborate with. He's one of the faculty in the CCPM. And so, he plans to look at these 27 variants to try and calculate a polygenic risk score for what the risk of thyroid cancer is, and use our data, the new patients that we're acquiring through the biobank, to study this, and also correlate those variants with clinical outcome. The other part of the CCPM is the Health Data Compass. So this takes all of the electronic health records from Epic, as well as billing information and other public sources, links those records and makes it available for research. So we obtained data from Compass on over 2,000 patients with thyroid cancer over the last 15 years. And we were very excited. It took quite some time to get our data, but we were very excited. And then they gave us the data, and it's basically free text of the pathology report. So this is, I know, hard to see here, but it's just the free text of the report. It's not broken down in all the discrete categorical variables that you want to know to have the granularity to study, outcomes for thyroid cancer, any cancer. This is just an example of what that looks like when you copy it into a Word document. So enter Martin Barrio's pathology keyword search algorithm, and I call it Automagical. So what Martin has been doing with Nikita and I is, we developed a keyword data dictionary for what do we want from the pathology reports to be able to do, very granular research on risk of recurrence and death for thyroid cancer. He developed an algorithm using this program, MATLAB. I won't go into all the details. I'll just tell you that this is the Automagic part, that he takes these reports that just is one cell that has the entire free text and is able to then break it down. It just runs the program on all of the patients in a spreadsheet, 1,700 patients with free text, and magically it all gets put into nice discrete columns with, what the T stage is, the max tumor size, positive nodes out of how many nodes were removed. It's really been unbelievable what he's been able to do in a very short period of time. So the first project that we're looking at for that is to look at the ATA risk of recurrence. So this is a published risk stratification that's used clinically, and we're going to look at our own data. And that's what his program does. It not only breaks out all the discrete variables, it tells us what the ATA risk recurrence for that particular patient was. Now we can use that to go back and try and look at the genomic data to say, okay, what about with these 27 variants? Is that going to alter risk? So that's kind of what we're doing, and hopefully we will come up with some new associations to further refine the care of papillary thyroid cancer patients. Thanks.
Thank you, Dr. Raeburn. Chris, that was a great talk. That research is going to be big. And it looks like you're really leveraging the big data push that this campus has put together in the last couple of years with recruiting probably some of the top informatics people in the world to this campus. So I congratulate you for that. We're running out of time, so I'm just going to make a quick comment in that, this is not so strange in terms of observing benign cancers, right? We do it for neuroendocrine tumors of the pancreas. We do it for kidney cancers that are small and don't seem to be growing. So, I mean, this makes sense, right? And it just took us a while to get there. And I think a lot of this is also a social issue when you talk to the patient, right? So, but
It takes a lot of time to convince them.
Yeah, 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 and the same thing with the other tumors. And with that, if anyone has any questions or comments, email Chris directly. Thank you so much. That was a great talk, very enlightening, and it's really neat to see the way this is evolving over time, over the 2 decades that I've been practicing. So thank you.